Hello my dear students, I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. Today I'm here to teach you the topic of scalp. First, one little request to you. If you want to really understand scalp well, my suggestion is just brush up on norma verticalis, norma frontalis and norma occipitalis. And if you feel I can't do it, then keep a skull with you. Okay, so that will help you to understand the bony attachments of the scalp a lot more easily. Let's begin then. One again request. This time, I want all of you to sit with a color pencils and a drawing book or with any drawing implement, electronic drawing implement. This helps you to draw when I'm telling you to draw. Okay, and remember, when you draw, you use another part of your brain to learn. Okay, and this helps in better recall. This is a research proved innovative method of teaching. So try and draw when I ask you to draw. Okay, thank you students. Let's dive into the subject by trying to solve an extremely simple MCQ. Okay, so which layer of scalp is essentially a flattened tendon? Is it skin? Is it connective tissue, aponeurosis, or loose subaponeurotic tissue? Many of you probably know the answer. Some of you probably are unsure. Okay. Some other questions such as write the nerve supply of scalp, enumerate the layers of scalp are often questions that are asked. And to be able to solve the MCQ or answer these questions well, you have to have the knowledge of scalp, which is what we are going to acquire today. Right. Scalp is a big topic. I want to divide it into two parts. First, I want to discuss with you the layers of scalp along with their applied anatomy. And in the next lecture, I'm going to talk about arterial supply, venous drainage, lymphatic and nerve supply and their related applied anatomy. Okay, so let's talk about the scalp and its layers today. First, I always tell my students, introduce the topic to yourself. What is scalp? Scalp is that part of your skin or soft tissue that covers your calvaria. Use your hand, put it on your head. Understand that this structure that you're feeling here is your scalp. It's the soft tissue that covers your calvaria. Anteriorly, please use your hand, students. Anteriorly, it extends down till the supraorbital margin here. Posteriorly, it extends backwards till the external occipital protuberance and the highest nuchal line. On the side, it extends along till the superior temporal line and the zygomatic arch. So it's like a little helmet that is placed on top of your head. That, my dear students, is the scalp. Right. So what is it made up of? Madam is talking about it. What is so special about it? Let's understand. Okay. So it's made up of 5 layers, okay? Lucky for us, the 5 layers are remembered by the mnemonic SCALP, scalp, okay? So, please come on to the screen and understand the outermost layer is called as S, skin. Next layer is C, connective tissue. Next layer is A, aponeurosis. Next, loose subaponeurotic tissue. And the next is pericranium. Take a look at this diagram, be comfortable, we are going to anyway learn to draw it, okay? And the nice thing is that in this diagram, I'm showing you a little more. See if you are comfortable with this knowledge. Here is your skull bone. Can you see the bone with the diploic tissue in the center? Here there are 2 layers if you can see. One is the endosteal layer of dura and the inner one is the meningeal layer of dura. Here is the arachnoid mater. See how thin web-like it is. And this is your cortex itself, cerebral cortex. So this is what this image is showing you. And the next thing we do is we pick up our drawing books, pick up our color pencils, and we draw the same thing. After having drawn it, we will be discussing each of the layers along with their applied anatomy. Right? Then let's begin our diagram, dear students. Alright students, let's begin our diagram. First, please draw on the outside the skin. Okay, so this outer layer is the skin. Remember to give that person a nice good amount of hair. Okay, let him be happy that he's got thick hair. Okay, now this is the lower edge of the skin. S for skin, that's the first layer we've drawn. The next layer is the layer of connective tissue, C for connective tissue. Inside this layer, remember to draw neurovascular bundles with using colors, using red, blue and yellow to indicate presence of veins, arteries and nerves respectively. Okay, so remember these are important. This is an important part of the diagram. Below this layer now we come to the next layer of A for aponeurosis. Below that layer you come to the layer of loose subaponeurotic connective tissue. In this, just draw a few fibers. Remember it's a loose tissue, so there will be only a few fibers and just a space there. Below this now we come to an important aspect. Concentrate now. First draw the skull bone here. Remember, the skull bone in the center is going to have diploic tissue there. The layer outside here is P for pericranium. S-C-A-L-P. P for pericranium. Inside here now draw the next layer, which is the layer of endosteum. Observe that the endosteum is continuous with the periosteum at the level of the suture. They are continuous at the suture. Come a little deeper now. Let's draw the meningeal layer of dura, which is flush with the endosteal layer of dura. Okay, and as it goes inwards, it separates from the endosteal layer of dura, producing what is called as the intracranial venous sinus. Inside this, of course, this is the layer of the arachnoid meter, and inside that is the cerebral cortex, as we saw in the diagram earlier. Now let's add one more important character to this diagram. Let's add our emissary vein. Emissary vein is a vein that extends throughout the scalp, connecting the superficial layers of scalp to the intracranial venous sinus, also having a connection to the diploic veins. So look carefully, we've got the 5 layers of scalp from outside inwards, S-C-A-L-P. Inside the periosteum is your cranial vault or the section of the cranial bone. Inside that is the endosteal layer of dura, meningeal layer of dura, arachnoid meter and the cerebral cortex. If you got this diagram, now understand that we will be discussing each of the layers henceforth. Alright students, leave your drawing books away and let's come back to the screen to discuss all of these 5 layers and their applied anatomy. Alright students, so let's talk about the first layer, the skin. The skin is thin, thick, it's got a lot of hair and it's having a dense network of sweat glands and sebaceous glands. Okay. How do we know it has sweat glands? When you come back from a jog, you find your hair is wet. That's because there's a lot of sweating happening through those dense network of sweat glands. You also find that when you have a bath, hair bath, and you come out, your hair is initially slightly dry. But you comb it, after some time you find that your hair has become glossy. Why is it glossy? It's because there is a dense network of sebaceous glands there, which is secreting the beautiful sebum that coats your hair. After a few days, the same hair becomes sticky because the sebum has made it sticky. So that is the work of sebaceous glands in your scalp. Let's now go to the next layer, the layer of dense connective tissue. Remember the word dense connective tissue. The mnemonic is C. But dense connective tissue is something you have to remember because its property is it is dense. Okay? It has got a good distribution of fibrofatty tissue and it contains blood vessels and nerves. Okay, remember in the diagram we drew blood vessels and nerves? That's because it has a very dense network of blood vessels and nerves. It connects the overlying skin to the underlying layer of aponeurosis. Does this layer have any applied anatomy? Yes, it does. Let's understand what it is. Scalp wounds bleed profusely. Why? Now understand that the blood vessel that is passing through this dense connective tissue its adventitia is fused with the connective tissue layer. The adventitia of the blood vessel is fused with the connective tissue layer. When the blood vessel gets cut by injury, it is unable to retract because the outer connective tissue hangs on to its wall. You understand? So the blood vessel remains open and keeps on bleeding, leading to a lot of hemorrhage. Okay? So question is, ma'am, how are we going to stop this bleeding? We can stop it by just compressing the blood vessel against the underlying skull bone. That's a good way of halting the hemorrhage. Does it have any advantages? Why has nature given it such a dense network of blood vessels? The advantage is that even if there is a massive avulsion injury, okay, sometimes large portions of the scalp just come off in an injury, you can still put that back on, suture it up, and hope that it heals. Why do we have that right to hope? Because there is such a dense network of blood supply that every part of that little of the scalp receives blood supply, and there is a good chance of its healing without sloughing off. Another thing, dense connective tissue, if it gets infected, if there is any infection in it, there is a lot of pain, but very little swelling. Can you tell me why? Why is there no swelling? That's because the connective tissue is dense. It doesn't allow for swelling. Imagine if I'm trying to open this fist and the surrounding tissue is not allowing it to open. So there will be pain, but there will be minimal swelling. So if there is inflammation in your scalp, swelling may not be there. So you feel there's nothing, but there is a lot of pain. With this, we go to the next layer, the wonderful layer of Galea Aponeurotica. Yes, let's come to the word Galea. What is Galea? Galea means a helmet. Okay. So Galea Aponeurotica is a aponeurotic layer stuck in our scalp like a helmet. Peculiarity is that it is interrupted by the muscle Occipitofrontalis, which consists of two bellies in the front, two frontal bellies, and two occipital bellies in the back. So basically a layer of aponeurosis with two muscles in the front called frontal bellies, two muscles at the back called occipital bellies, and both these muscles together are referred to as Occipitofrontalis muscle. Let's talk about the aponeurosis first, okay? So the aponeurosis is anteriorly, remember to palpate, okay? Is anteriorly extending forwards almost till the base of your nose, okay? It extends between the, see this diagram here? It extends in this narrow gap between the two frontal bellies. Similarly, it goes posteriorly and extends in this wide gap between the two occipital bellies, extending down till the highest nuchal line. On the side, it begins to cover your skull, reaching the superior temporal line, then crossing superficial to the temporal fascia and getting attached to the zygomatic arch. So these are the anterior, posterior and side attachments or lateral attachments of your Galea Aponeurotica. Remember one thing, galleal fibers are oriented anteroposteriorly. Now this is something you have to understand, okay? You have to use your brain. Suppose this is my Galea Aponeurotica, the fibers are longitudinally placed. Here is my frontalis, here is my occipitalis, okay? Suppose the injury is longitudinal, along the direction of fibers, then the injury does not gape, okay? But if it is horizontal, it is perpendicular to the direction of fibers, then the frontalis and occipitalis pull the two edges apart, causing the injury to gape. Okay, in that case, you would have to pull the two edges together and suture them up for better healing. Alright, I hope you've understood this. Remember, wounds gape widely if Galea is cut transversely. Okay, right. So let's talk about frontal and occipital bellies. Frontal are two bellies situated anteriorly. Remember, it's important that they don't have a bony attachment. They are attached into the skin And the contraction of frontal bellies causes you to give a expression of surprise. Hey! Okay? And what happens? You get this beautiful or whatever horizontal creases on your forehead. That's your frontalis muscle. Similarly, go to the occipital bellies. They're attached to the nuchal lines here, a little bit to the mastoid bone. Okay. However, see, they have a bony attachment. Frontal bellies do not have a bony attachment. As you can see, both are supplied by branches of facial nerve. Anteriorly, temporal branch of facial, posteriorly, posterior auricular branch of facial. Pause. What does this make you understand? If they are supplied by facial nerve, what is their development? Yes, they develop from second branchial arch, and therefore they get a nerve supply from facial nerve. I hope all of you got this. Always use logic better than mugging. Okay? Right. So let's come back to our MCQ with which we started. Which layer of scalp is essentially a flattened tendon? Now can you tell me which is the flattened tendon? Of course, it's the layer of aponeurosis, option C. So knowledge will help you solve MCQs way faster and with way more confidence. Right. So let's come to the next layer, the amazing layer of loose areolar tissue. Why is it amazing? You're going to find out very soon. Okay. So what is different about this layer? Funnily, this layer is basically a potential space. It's just a space between the aponeurosis and the underlying periosteum. Okay, with a little bit of tissue in it. The important thing is it is traversed by emissary veins. You look at the image and understand how this layer is traversed by the emissary vein here, connecting the veins of the scalp to the diploic veins as well as to the intracranial venous sinuses. So now you're wondering, why is madam giving me all this, so much of data? It's very important, dear students, because we come to the applied importance of loose aponeurotic tissue, loose subaponeurotic tissue. Okay. Now this layer is called as the dangerous area of scalp. Why is it dangerous? It's just a potential space, isn't it? So understand that when there are infections, the infections begin to get collected in this potential space. Okay. So one infection is collected in the potential space. Now what does the valveless emissary vein do? Remember, emissary veins have no valves. They begin to pass through this loose areolar tissue space, connecting this space to the diploic veins in the skull bone and to the intracranial sinus inside the cranial cavity. So what is it going to do? It's going to pick up infection from the loose subaponeurotic tissue layer and carry it to the skull, causing osteomyelitis, carrying inside the brain, causing intracranial infection. Okay, so that's why this layer is called as a dangerous area of scalp. Right. Oh, what has happened to this man? Yes, obviously it's black eye. Do you think somebody punched him in the eye? The reality is a little different. What happened was he has got hit on the head. There has been a hemorrhage. The blood has got collected in his loose subaponeurotic tissue layer. As the blood is moving, right? So it can go back, but it's stopped by the occipital attachment to the bone. It can go on the side, it is stopped by the attachment to the zygomatic arch. But when the blood gravitates forward, the frontal bellies have no bony attachment underlying. So because of that, they are able to flow, the blood is able to flow forwards and enter into the loose areolar tissue around your orbit. Because the blood gravitates here, it looks like a black eye. Okay, and this is a black eye where the injury is somewhere else and the lesion is showing around the eye. So this is called black eye, and this is the involvement of loose aponeurotic tissue in formation of this black eye. Right. A hematoma in your loose subaponeurotic tissue is called as safety valve hematoma. Complicated, isn't it? It's beautiful. Understand. Okay. What happens is when you can see that this person is having a skull fracture here. Okay. So what has happened because the skull has got fractured? Blood starts to collect in the brain. But it's able to find a way through this gap and it begins to get collected in the loose subaponeurotic tissue layer. Had it not found this path, it would have collected inside your cranial cavity, causing compression of your brain, which is serious. So, because the space of loose subaponeurotic tissue is there, blood collects in that layer, not compressing the brain. Thus, this hematoma is acting as a safety valve for the brain. Hence, it's called as safety valve hematoma. That's the direction in which the blood goes. Oh, what has happened to this child? This child is having what is called as Caput succedaneum. So what happens when during the process of delivery, sometimes the delivery is very excruciating and very prolonged. The pressure of the surrounding uterus and cervix on the baby leads to a lot of edema. So this thing that you're seeing here on the top is actually a collection of fluid there, edematous fluid. Once the baby is born, usually Caput succedaneum resolves itself over time. So it is not limited to one half of your skull. It can easily cross midline because it's a swelling in the superficial layers of scalp. Okay. Now let's come to, oh, isn't it interesting? Suddenly the lecture got very interesting, isn't it? What is this red Indian doing? What is he carrying in his hand? Yes, it looks like a scalp. Can you see that this scalp is the missing scalp from this man's head? This process is called as scalping. So, anatomically, you should know that the cut is made in the loose subaponeurotic tissue layer and the top three layers are removed. And this is acting as a trophy. This red Indian is going to go and show it to the leader of his pack and tell him, see, this is the guy I have killed and I've got you his scalp. Okay, this is called scalping injury. Anatomy sometimes is terribly interesting, isn't it? So now this scalp acts as a victory trophy. Right. We come to the last layer, students, the layer of pericranium. Okay, take a look at it. Be sure you know where it is. Okay, so S, C, A, L and P. This green layer is your pericranium. Observe how it becomes continuous with the endosteal layer of dura, okay, at the suture line. It's loosely attached to this skull bone, okay. So now, how does it matter? Here you're seeing a swelling. This is the area where there is a fracture. The blood has started to collect below the pericranium. Can you understand? Below the pericranium, between the skull, right? As this swelling increases in size, it reaches the edge of the suture here. But it is unable to cross over onto the opposite side. You understand? It is limited by the suture. So now, above, this is your pericranium. This swelling collection of blood is called cephalo-hematoma. What is it called? Please say it once. Cephalo-hematoma. This swelling will be limited to the shape of the skull bone. Okay. Above this, now you're seeing one more swelling, that is the Caput succedaneum. Now this Caput succedaneum is easily able to cross midline because it is not limited by any suture. It's a swelling in the higher layers, right? You understand? So this is the applied importance of pericranium. Sometimes CSF can get collected post-fracture, in which case the swelling is called cephalo-hydrocele. Right, my dear students. Let's now quickly run through what we've covered in today's lecture. We've discussed the 5 layers SCALP. We've drawn the diagram. We've discussed the applied anatomy of each layer. We've come across some fantastic terms: dangerous area of scalp, safety valve hematoma, cephalohematoma, Caput succedaneum, cephalohydrocele, black eye, and scalping. So all this is interesting reading, but what is left is the arterial and venous supply, the nerve supply, lymphatic drainage, and their related anatomy. I request all of you to attend my next lecture. The link is given in the comment section. And that way you will be completing the topic of scalp completely. Scalp 1 is what we've done today. Scalp 2 is where I want you to go next. Okay. With this, I complete my lecture. There are some MCQs which I expect you to solve. If you have problems, feel free to contact me. As usual, as a teacher, I feel like advising you. Remember, opportunities don't just happen, you have to create them. So work hard, pick up every little chance which you will convert into an opportunity. Okay? Thank you, students. See you across the screen in some other video. Keep learning, keep studying. Remember, keep drawing. Thank you.